Okay, so welcome everybody. I'm Pam Smith, I'm chair today. I'm a lay member on the governing body of the Cheshire Clinical Commissioning Group, and this is a live webinar. Although it's a meeting in public, it's not a public meeting. I've already asked people to keep their microphones off when they're not speaking, but I rather than go around and introduce everybody, what I would ask is when you do speak, you introduce yourself. If you want to speak, then do that via the chat box, and I'll endeavour to keep up to speed with who's asking to speak. And I just say that if people have made a point that you want to make already, don't make it. We don't need people to say, oh, yes, I agree with that. We're trying to get through quite a hefty agenda this morning in quite a short time. We're quorate, so we can go straight on to the agenda. I've had apologies from absence from Fiona McGregor Smith and Suzanne Horrell. Christine, have we had any more? Can't hear Christine.
No, not that was sent to me.
Okay, that's lovely, thanks. In terms of declarations of interest, we must have some declarations of interest because I assume that all the GPs are conflicted in terms of the care homes paper. But are there any other declarations apart from that? No? Good. Okay. So I'll move on. I haven't received any public questions. Neil, have there been any that I'm not aware of?
I've not been alerted to any public questions for this meeting, Pam.
No, I haven't either. So I'm making an assumption that there aren't any questions from the public. And because we do ask for those to be sent to us before the meeting when the papers are actually put on the website. So can we now move to the minutes of the last meeting, which were held on the 24th of June, which seems like ages ago. Has anybody got any factual inaccuracies on any of these pages? I think they've been circulated before to people. No, no one has. I actually picked up a double word on page 7. Halfway down it says, it's the big paragraph that starts, the committee asked for clarity around the purpose of the impact. The last paragraph has got 2 howevers in it, Christine, so if you could just change those. Has anybody identified anything on here that should be on the tracker that isn't? No, okay. So can we agree that those are the minutes and we can sign those off? Yes, everybody's happy with that. So we can move on to the action log. The first one is the funding variation. Linda, how are we getting on with that?
Well, because of the current financial framework and arrangements, really that's no longer actually a current request, I would suggest. We can go back to that when we know how much funding we're going to get and how that is going to be calculated. At the moment, we don't know. It is certainly not part of the allocation that we're receiving until the end of September. And until we find out what is going to happen from that point on, this is kind of like not relevant anymore because of the way in which we're being funded now. So I think we could probably close that and reopen it once we've had further guidance, or we understand how this is going to happen going forward.
I'm quite happy with that. It was about the East had non-recurrent funding, wasn't it? And everybody else had got.
Well, there was an element of non-recurrent funding, but there was also the fact that the amount of monies that we were paying under GMS delegated were greater than the budget that we'd been actually allocated as well. So I think that was the bit that I was going to go back and discuss. But given that we have an allocation now which is being set nationally based on last year, but not including non-recurrent and various other things, I don't think that that question at the moment is sort of appropriate.
Okay. We'll take it off the action log then.
Thank
Neil,
you.
the next one is over to you.
Yeah, I think the next few are mine. So A5, we've completed that action. We communicated out to practices the outcome of the review around last year's QOF. We have received an appeal following that, which is being heard this afternoon to review some additional evidence that a practice has sent us. So, but we have completed the action as was described at the last committee.
Okay, thanks. And the next one?
Yeah, that's on the agenda in the second meeting today.
Yeah. I'm not sure if we've had a discussion on the governance.
Yeah.
We haven't
So I think we need to follow that up after the membership meetings that happened in July, at the end of July, on the basis that the speed of that process, we have slightly slowed and prioritised some areas off the feedback from practices. So I think that's possibly not quite as urgent as it was when we were talking about completing that work before Christmas. Which we aren't now proposing, but we do need to have the conversation, Pam, in readiness for 2021.
Okay. And in terms of A7, no, not A8.
A8. Yes, so that was discussed at the membership meetings, and a communication's gone out from Andrew Wilson to practices this week, which includes practices being asked to confirm whether they wish to use their governing body representative or nominate an alternative GP. So that's gone out, I think, on Monday of this week.
Okay. And finally, future meeting dates are down to me, but we've actually managed to shift this one to a Thursday. And I assume that we moved the next one to a Thursday as well.
Yes.
Yeah, okay. So that's...
Following the request that they'll all be on Thursdays going forward. The reason we've not confirmed beyond November is because there is a review happening about where all the meetings sit, I'm afraid, in terms of which week of the month. So until that's completed, we didn't want to put the dates in diary quite yet, but we have noted the request for Thursdays. Okay,
that's lovely. Thanks, Neil. Okay, so let's move on to the main business on the agenda. The first one is the enhanced care in care homes. I'm assuming that everybody has read the paper. It's a very detailed paper. And basically, I'm going to ask Tanya to maybe speak to it, but actually to take us through the options at section 7 rather than go through the whole paper. So can I hand over to you, Tanya?
Yeah, of course. Excuse me.
Yeah.
A number of the panelists have a direct conflict of interest, and under the guidance around conflict of interest, we need to decide at the beginning how we're going to deal with that conflict of interest, whether we're going to ask those people who are conflicted to remain silent through the discussion, or whether we're going to ask them to leave, etc. Thank you.
Thank you, Linda, for reminding me of that, because I did mention it right at the beginning in terms of conflicts, but I'd forgotten that I have to deal with that first. The GPs on the panel or on the committee are actually conflicted. Because it's so difficult to get in and out of this meeting, I am going to state that they can hear what's said, but they actually can't take part in the discussion. So that needs to be minuted. They're not voting members anyway, but they actually can't take part in the discussion. So you can hear and I can see your faces, but that's what I'm going to ask that happens, if that's okay. Sorry, thanks for that, Linda. Tanya.
Yep, of course. So instead of giving a summary of the paper, then I'll go straight into the options on the basis that I'm hoping people have read the extensive consultation and review that has taken place since the last meeting on the request of Primary Care Commissioning Committee, and also within the paper has managed to have a look at the detailed outcomes that we have investigated and understood in terms of what the potential could be going forward if we implement the new specification. And also the different funding models that we have considered based on that return on investment. So in terms of section 7, as Pam has said, in terms of those different options available, obviously now we have completed that review and we have assessed the options and the outcomes that have been achieved to date and could be achieved going forward based on what we decide to implement. There are a number of options on the table really for Primary Care Commissioning Committee and the CCG. The first is, as is always the case in an options appraisal, to do nothing. What this would mean is that the direct enhanced service, or the DES, would come into effect in terms of delivery from the 1st of October. And the existing position would remain, which is that the 5 existing different local enhanced services around care homes would stay in place across Cheshire. Unfortunately, what this would do is it would mean that we were locally duplicating the requirements of the National Direct Enhanced Service. So we would be asking our practices locally to do things that they are also being asked to do nationally, which would in effect mean that we were also duplicating our payment to practices. It would also mean that we are not looking at that equity across primary care and trying to get to a position where the contracting framework around Cheshire is in alignment and is consistent, and also making sure that those outcomes that we're seeing being delivered are being done so consistently across Cheshire. So that is not the recommended option. The second option that is on the table would be to commission the DES as we're required to do nationally, so that national framework around enhancing care and care homes. But whilst we commission that DES, decommission essentially our local enhanced schemes for care homes. So we would no longer have those 5 different contracts across Cheshire asking practices to do something slightly different in care homes and asking them potentially to duplicate the work of the national scheme. The advantage of that is obviously that would enable there to be a new pot of funding available. However, that would still have to be utilised within primary care. It states specifically in the direct enhanced service contract that any funding that no longer goes to practices because of the national scheme duplicating the local requirements still does need to be invested in primary care. So we would need to come up with a plan of how we're going to utilise that funding differently in primary care. Also, this is not the recommended option of the Task and Finish group or their local medical committee, who we have engaged with as part of the consultation process. As obviously as can be seen within the paper, significant outcomes have been achieved for patients, primarily in nursing homes, which are the patients currently covered by the scheme, by utilising a larger pot of funding as is available nationally in the direct enhanced service, and therefore potentially the outcomes that we're currently achieving within nursing homes would no longer be achieved for patients because of the reduction in funding and therefore the reduction in staffing available to complete the work, and also replicating those outcomes in the homes that are not currently covered, so primarily residential homes wouldn't take place. So again, that isn't the recommended option. The next option is to commission the local enhanced scheme still over and above the direct enhanced service, and that would be the local enhanced service specification that you have seen as one of the appendices within the paper that we have worked very closely with numerous partners around to develop, and has been agreed by the Task and Finish group. So to continue to commission that local enhanced service over and above the DES, but to do so in a way that is consistent across Cheshire, so it stops us having those 5 different contracts in place and leads to equity around the funding model. It would also mean that the outcomes that we're currently being seen and delivered in the nursing homes could be spread to the residential homes and the learning disability homes as well, so we could see those positive outcomes for patients across the board through the care home sector. However, the different funding models that are available to us essentially will depend on what the CCG wishes to see in terms of cost pressure to the budget, but also in terms of alignment to the commissioning intentions, and also around how extensive they wish to see those patient outcomes be delivered in those homes that have not previously been covered by the LERS. So the first option is to commission the LERS at a cost neutral tariff. What this essentially means is the national budget that's been made available for the direct enhanced service, which on an annual basis works out as £120 per bed, and that's total beds, whether those beds are occupied or not, would be added to the current different budget we've got in place for each of the old or historic CCG areas across Cheshire. So that budget would be pooled with the DES and then split out either based on all beds, whether occupied or not, or based on occupied beds only for the local enhanced service element. And that would then mean we would have either, if it's between all beds as per the DES contractual requirements, would be around £303 per bed available in Cheshire, or if we split that just based on the local enhanced service beds that are occupied, that would be on the basis of £329 per bed. So in terms of what the impact of that would mean for the CCG, essentially that would mean that the current investment in primary care for the local enhanced service and care homes would continue. So our budget, as it were, would remain the same, but in addition we would add that new pot of funding that's available through NHS England as a direct enhanced service to that, to enable a new tariff to be available for either all occupied beds or for all beds. In terms of what that would mean for practices, the vast majority of PCNs, primary care networks, a group of practices, would see an increase in the funding that's available to them. So they would see additional funding due to that new funding coming from the direct enhanced service. Other than in 3 PCNs where they have previously covered all beds within care homes anyway, so they have already been covering all beds, which would mean that essentially they see a reduction in tariff. It would therefore be important for those 3 PCNs that we would work closely with them to understand why that budget has decreased, and where possible come up with a transitional arrangement for them so that they are not essentially seeing a decrease in the income available due to obviously the impact that might mean on staffing. The main disadvantage in this option is that the tariff would reduce, but as I've said, the budget as a whole would increase because more beds would cover. So most PCNs and practices would see an increase in funding. However, it's not necessarily the case that the increase in funding is proportionate to the increase in workload, because we are now asking them to look after more beds, or in some areas a reduced tariff. So potentially the patient outcomes that we would wish to see may not be maximised in that model, and subsequently, having shared that with the Task and Finish group and the local medical committee, the LMC, that is not the recommended option for that reason. It also doesn't in line with our commissioning intentions as an organisation. The second option is to, and this is a recommended option, would be to continue to commission a local enhanced service over and above the national direct enhanced service, but to do, as is quoted in the commissioning intentions, that by levelling up the funding to practices and essentially bringing all beds up to the maximum rate that is currently paid actually in West Cheshire in terms of historical organisation. So that would move the tariff up to £377 per bed, and we could either base that on occupied beds, which obviously has a risk because that means that the number of beds covered may fluctuate through the year, and therefore our budget available for the practices and in terms of our risk to the CCG would fluctuate through the year. That would also mean that there would be a cost pressure for the CCG, as we would need to invest over and above what we currently invest in our local enhanced service, and now that has been delegated to us in the direct enhanced service. And dependent on whether we base that on occupied beds or on all beds, that cost pressure would essentially be either £302,000 annually or £539,000 annually. However, the advantages of that option is it would allow practices to have more funding to employ more staff, as now more beds are being covered by the scheme, so we've now got residential beds covered as well. It would also mean that no individual PCN sees a reduction in funding, and it will also mean that the likelihood of achieving those patient outcomes, as quoted within the paper, that could potentially result in a £1.2 million saving on the emergency contracts with our acute providers, that would have the most likelihood of being achieved. The final option is to continue the review, say that none of the options that we have looked at are agreed option, so continue the review and potentially look at funding residential beds at a different impact than or a different tariff than nursing beds. However, this has not been the recommended option to date by the clinicians who have taken part of the task and finish group, with the feeling that actually the amount of work involved and the input that residential patients need is often on par with the same input that's required of nursing home patients. So therefore that option has not been recommended by the task and finish group, but that is something that we could look at in more detail if the Primary Care Commissioning Committee felt that that was an option that we needed to explore further. So in terms of the kind of majority of the paper, the recommended option is to increase the investment in primary care over and above the budget that's available for the direct enhanced service and the current local enhanced services, and to also increase that, now taking into account the new beds that practices are being asked to cover, and to ensure that we are in line with our commissioning intentions. That is the recommended option that has come from the task and finish group and is in agreement with the local medical committee. The other part of the paper and the option that's not displayed within that section because it's been kept separate due to the slightly separate issues involved, is around the three very specific neurodisability homes that at the moment we have not been able to meet our NHS England contractual requirements of ensuring they're aligned to a PCN and hopefully within that a practice, in terms of getting that done by the 31st of July for the PCN Primary Care Network Direct Enhanced Service. And that is because of the complexity of the patients within, and at the moment the vast majority or vast scale of practices that the patients within those homes are registered at. So there would need to be very specific work taking place to support the more complex patients within those initially 3 homes, neurodisability homes, to ensure that we have the right model of care being delivered by the GP practices, to ensure that where possible the patient outcomes are maximised for those homes. And the costing model that has been put forward to support that additional input into those homes has been done so on the basis of a lot of input from the GP practices who would look after patients within those homes, from the care homes staff themselves, the care homes managers, and also working in collaboration with the neurodisability rehabilitation team and the Walton Centre. So the costs put forward have been done so on the basis of what input would be required from the GP practices, but obviously this is asking for additional investment over and above what we currently make to the care homes, and would enable the CCG to see an additional cost pressure of around, I think it's around £54,000 annually. So that's a summary of the options available in the paper, and I'm happy to take any questions.
Okay, thanks for that, Tanya. That was a really thorough summary as well. Just before I open it to questions, just a few comments from me. I mean, the first thing for me is that it's not, I shouldn't think it's a surprise that we've had the direct enhanced service, because there's a lot of pressure put on us to work with nursing homes because of COVID, and that's right and proper. The second, however, is that we're in a financial situation where we're heavily in deficit. So any investment has got to be found from somewhere. And the third is that investment is not within the gift of this committee, because we only have the authority to spend the budget that's designated or delegated to us by NHS England, and this is not a delegated budget. It would have to come out of the general pot, methinks, Linda, and that means that we would have to actually go to governing body if we wanted to make any further investments. So we can go ahead and debate which options we want to choose, but we do have to bear in mind, if we choose any that involves an investment, that will have to go to governing body. We don't have the power to make that decision. And it also seems from me, from what you've said, Tanya, option one is not an option. But we could go with option two, which is decommission the local enhanced service and use that primary care money somewhere else in primary care. But that would cause some destabilisation in our primary care service. So I think probably we just need to look at that, debate that one, but then we're needing to look at whether we go for the cost neutral option or whether we then ask for further investment. The other thing at the moment, of course, is it may be that we can demonstrate over the next 6 months that we actually make a difference in terms of admissions to hospital, and we would make a cost saving. But at the moment, because we're in command and control, we're not going to make any saving at all, because the government is insisting, or NHS England is insisting, that we pay the hospitals as we've always paid them. So we can't take that money out of the system, whereas under normal circumstances we could. I think I'm right in that as well, Linda, aren't I? Yeah, Linda
yes,
said
I would like to confirm everything you have so far said in terms of what this committee is allowed to do in terms of the budget. Any additional funding above would be from programme, and therefore would need to go through under G2 on the SFA, on the standing financial instructions, and therefore would need to go to the governing body. And also the block contract payments, which we are under, which we will be under for the rest of the year, I think, also removes any ability to reduce the funding going into the acute sector, unless our integrated care providers can move the money around within their organisations. But as we stand now, we will continue to pay them block.
Okay, thanks, Linda. I've had some comments from Suzanne Horrell, who's on holiday, but she sent me an email regarding today's meeting. And basically, she's very concerned about the finance. She's concerned that she doesn't know whether the finance team have been involved in looking at this funding or whether there is any funding available. And she's put, what is the financial envelope and what is the current and projected deficit? Because this is an annual cost, it's not a one-off cost. And it's a significant cost as well. And she was worried that the paper was biased in terms of the financial sustainability of primary care. She felt that that was a big push, that we need to do this because we need to maintain the stability in primary care, but she still wasn't sure whether it was value for money, I think is what she's saying. Is that a good summary? I know, Wendy, she sent that to you as well. Do you feel that's I've covered her points?
Yeah, yes, I think she was. I think she's obviously wants, like we all do, I think, is a continued investment in primary care. It's part of our strategic objectives. That's where we're going. But it's around what is the best way of doing this. I think she was concerned about levelling up to that point with no real knowledge about where that's coming from. Where that money will come from, and what are the real benefits, and can we actually measure those? And I suppose the additional things that I'm thinking around is, you mentioned that occupancy would actually fluctuate throughout the year. What's the problem with that? I don't understand that paying for actual occupancies, to me, seems, if we levelled up, that would be a more valid way of managing it, rather than trying to, because we've got good estimates and we know that some of the numbers in care homes are dropping. So can you explain that a little bit more to me? Because I'm not really clear on why this is not really a good option.
Yeah, am I all right to answer that question, Pam?
Yes, fine.
Yeah. So in terms of the occupancy of the nursing home, I can understand your point, but from a GP practice perspective, they will need to employ staff to deliver this service, and obviously in employing maybe an advanced nurse practitioner or a GP to deliver the service, that member of staff will still need to be employed, whether the occupancy is at 100% or 75%. So by funding on the basis of occupancy, the funding levels going out to GP practices would fluctuate, but GP practices would still have the same responsibility in terms of employing staff to deliver the service. You know, their staffing levels, it wouldn't be possible to fluctuate that throughout the year. So in terms of a GP practice stability, being able to employ staff in order to deliver the service, you know, that would be very difficult to do if the income they receive to employ those, you know, members of staff fluctuated through the year. It would be very difficult from an employment perspective.
Tanya, further to that answer then, could you actually go for option 1A now and then do some work over the next 6 months, recognizing that we're not
Pam appears to have that cloud issue she referred to, where she said she might freeze.
Oh, am I back?
Oh, you're back, Pam, yeah.
Yeah. What I'm saying is, could we go for option 1A, which is basically the status quo, but do some work over the next 6 months and then look at it again in April, new financial year, maybe different funding mechanism?
When you say option 1A, that's on the basis of, do you mean on the basis of occupied beds or on total beds? Are you talking about the total beds option?
Yeah, whichever's cost neutral really to us.
Yeah, so both of those options are essentially cost neutral. However, what they do mean is the funding available to practices would fluctuate dependent on whether we look at total beds, which is what the National Direct Enhanced Service requires us to do. So we would pay for total beds within the DES, or potentially, as Wendy was just talking about, we could pay for occupied beds only. The issue with that is all those risks that I just spoke about. And in both of those options, the funding available to practices would either be lower or higher, depending on whether we paid occupied or total beds. What it would mean is there are 3 primary care networks that would essentially now be covering more beds, but their funding would have reduced because the tariff price for them would reduce, and they've previously covered all beds. So there would still be a very small cost pressure for the CCG whilst we work with those 3 primary care networks to understand why their funding has reduced and where possible to try and agree to a transitional arrangement to make sure that they're not destabilised. However, the disadvantage around that is essentially we would be asking practices to now be looking after more patients, as they would now be looking after patients in residential homes as well as nursing homes. And although there would be additional funding from the Direct Enhanced Service, that wouldn't be proportionate to the additional staffing time that they would need to deliver the service. So although that would be cost neutral for the CCG and the majority of primary care networks would see additional funding, that wouldn't be proportionate to the amount of beds that they've taken on, the amount of additional beds. So it would mean that the current service could not be in the same way as in nursing homes replicated in the new homes. It would mean potentially a slight watering down of the service, which might mean that obviously the potential patient outcomes that we have analysed that could be achieved is less likely to be achieved.
Okay, Neil, you want to come in, and then Dan, I'll bring Dan in.
Yeah, and Dan's point links a bit to what I was going to say. I just wanted to clarify the point on the 1A and 2A approaches, which is whether we're going to pay on beds or people, and to some extent, it's a conversation we can have after making the decision on whether we're investing more money or not. In terms of my point, which Tanya can come back in a minute, is I guess the practicality of being able to pay on occupancy, and whether we flows of data from local authorities and homes to allow us to accurately do that on a monthly or quarterly basis, whatever frequency we chose. I guess my other point was, assuming that we recognise some homes will see greater fluctuation, but if we work on the basis that many homes will have a reasonably consistent occupancy flows up or down, whether it's winter leading to increased vacancies or whatever the reason may be. So I guess there's something around the practicality of doing it, and Dan's point there around whether you use some kind of middle ground, I guess, fits into that, being to some extent, does it matter, I guess, is what I'm getting at, whether you use a total beds or average occupied beds. It's a formula that we're using and put in place. All that it does is changes what you're calling the tariff. If we say that the tariff's £300 if it's on beds, but because you're using a different numerator and denominator by using occupied beds, it suddenly becomes £320. So I guess I'm mindful we might focus a lot on which one we use, but unless Tanya or someone tells me differently, I'm guessing it's probably not the important point in the discussion, because we can sort that out after in discussions with practices and LMC in terms of which one's the most effective model to use, but the endpoint being broadly the same, other than one carries slightly more risk for both parties because it's more variable.
Okay.
That's
Does anybody else want to come in?
I was just going to add to that, Pam, the other slight difference that occupancy makes, and this is really more for the GP practices to consider, like Neil said, in terms of our conversations with them based on the decision made today, is occupancy, although also changes the tariff available to practices, it also changes where that funding shifts. Because in obviously some areas of the Cheshire Patch have been more, for example, impacted by COVID than other areas, and therefore the occupancy levels have taken, more of a reduction in certain areas compared to other areas. So it also shifts the overall budget in terms of where that goes across the Cheshire Patch.
Okay. Paula, do you have a view?
Yeah, I've got a couple of things I fundamentally agree with that I think that we need to kind of embed in our decision making, really, which is about commitments we've given about, stability to practices. So I think that's been a point well made on a number of occasions by Tanya today. And I think there is something about that stability that we have to take account of. I think Neil's got a point to kind of say it's half a dozen of one and six of the other in terms of which funding model you use, about whether it's occupied or the beds available. I think as a practice, you're looking at some fixed costs here, and if you want to go for the kind of outcomes that we're looking for, you're going to need staff with a certain skill level who want to work at X number of hours, whether they be nurses, therapists, GPs. So I'm in a point where I think the number of beds in your patch makes more sense to me in terms of trying to deliver a fixed cost service with really good outcomes. I recognise what Neil's saying, that might be a moot point, but I think for me it's about principles, and it's about acknowledging the quality of the service that we want to see delivered. I think we've heard some points today about issues between residential homes and nursing homes. I think over the years we have seen the complexity of people that now live in residential homes increase. And when I'm in nursing homes, it feels to me like like a subacute ward, and the complexity of care that's being managed there. And I certainly, in terms of what the care that's provided in residential care, I think is at the upper ends now of some of the complexity. With the home first model, where people are encouraged to stay at home for as long as possible, and in actual fact I think sometimes the effort that goes into supporting people in residential homes to keep people living in a residential end of life is significant. So I think that it was helpful to see that point made there about what is the difference between residential homes and nursing homes. So some principles for me about paying for high quality outcomes, for fixed and stable costs, for understanding the complexity actually of the people who live in residential and nursing homes. And my challenge those to all those points of stability and acknowledging what it is that we want to achieve is that what that then means from a cost perspective. And I recognise it's not within the gift of this committee to push us to a place where we agree costs that are unaffordable. So there's lots of principles I think I agree with that I've heard today. It would be hard to disagree with them, but I am not yet seeing, although I'm fairly sure it exists based on lots of conversations I've had with colleagues, is how we evidence the value for money to take us that different place in terms of options around outcomes. And I'm sure we could hear lots of evidence about it, but how we see that demonstrable evidence which makes that case for those principles that I've heard today so clearly, I'm not sure we yet have that evidence base for the value.
Okay, thanks. Wendy, do you have a view? Oh, I can't hear you.
Sorry, I was just starting to type something. Yes, I do. One of the things I looked at this stakeholder engagement, which was pretty significant, and I saw that the local authority colleagues, etc., were involved. I didn't see any of our secondary care colleagues involved in that, and I'm wondering if some of our added value that Paul has just been discussing at the end there, because one of the things we want to do is to get many more elderly patients out of hospital more quickly into an appropriate setting. Did we actually consider looking at some sort of joint working or more close working in a different way to actually try to encourage our care home beds, seeing that rapid discharge from hospital, so that there was a collective work going on between local authorities, the secondary care and ourselves in the funding, and that may be a better way of distributing the costs.
Can anybody answer that for me?
In terms of the review, so you might have seen in the National Direct Enhanced Service, and it is referenced also in the local enhanced service, there is a requirement within that to work with secondary care colleagues on an individual practice or PCN level to enable those more efficient, timely discharges, exactly as you're talking about. In terms of how secondary care colleagues have been involved in review, they haven't necessarily been directly involved. So in terms of our task and finish group, we didn't have secondary care colleagues within that discussion. However, we did have our community care team colleagues who linked directly to their secondary care counterparts, and we also included our commissioning colleagues who work with secondary care. So although we didn't have a secondary care manager or consultant as part of that task and finish group, through our commissioning connections and community care team connections, their view has had an input, but it is a specific requirement in that direct enhanced service to link with secondary care to enable that faster discharge. And in terms of the outcomes that we've been able to demonstrate, as can be seen within the paper, we've been able to demonstrate in the homes that are covered currently by the local enhanced service, there is a reduction in terms of ambulance call-outs, in terms of A&E attendances and emergency admissions, and we've been able to demonstrate that if those outcomes were replicated in the homes that currently haven't got a local enhanced service in place, so that's mainly residential homes, there is the possibility of achieving a maximum of £1.2 million savings in terms of the emergency admissions contract, although completely take your point, Pam, that is currently a block contract. But as we've seen from the research that I've carried out on a national basis, the model of care that has been described nationally, the vanguard CCGs that have worked together to enable the current direct enhanced service framework to be written. We have made sure that both in the DES itself, but also in what we've commissioned locally, we are reflecting that model that we know has got demonstrable improvement in patient outcomes, both in terms of emergency activity, but also in terms of wider outcomes around positive feedback from family and carers, around coordination of care, which has been a real big theme when I've been talking to patients and also care home staff and local authority staff, that coordination of care and breaking down those barriers between the different providers has been one of the main efficiencies that they've seen from the local enhanced scheme, but also other wider positives around utilisation of medicine and patients feeling that the care they're receiving is centred around them and reflects their goals. So that wider research has been undertaken nationally. As I say, in terms of the outcomes we've managed to monitor locally, they have focused up until now mainly around emergency activity within hospital, and that is demonstrating improvements. But if we wish to implement this scheme going forward, I've worked very closely with my quality colleagues to look at how, and also end-of-life colleagues, to look at how we could implement a more qualitative dashboard that still would monitor those outcomes around emergency activity, would also monitor things that are more important, that you know, the patients feel reflects and the care homes feel reflects those positives that they would see, and also other determinants of quality around medicines, around CQC registration, you know, around a much wider breadth of outcomes that we wish to see. So if this scheme was implemented, we would have that dashboard to help us monitor that going forward.
Okay, thanks, Tanya. Does anybody else want to come in here before we, yeah, Louise?
Briefly, really, just to echo what Tanya's saying, so and it's been asked if there's work going on elsewhere. I can't speak for East ICP because I'm not sure where they're up to, but certainly for West, there's a whole working group going on around discharge and long-term care. And I know Tanya has spoken with Lee Calvert because I spoke to Lee last night. And so this is very much part of the thinking. The dashboard is going to be just absolutely invaluable to that piece of work, and linking that into the local authorities' business intelligence. So it's kind of stitched in, and it was really refreshing to see a paper that was so stitched in to a piece of work that was also going on elsewhere. So I think just in terms of of Wendy's point about secondary care and are they involved, and is there, yeah, that's a kind of absolutely partnership across the whole patch for the ICP. Can't speak for East because I don't have the same amount of knowledge, but definitely for West that this is embedded. So just to give that reassurance.
Okay, thanks. Linda, you wanted to make a point too.
Yes, thank you. I suppose I'd just like to sort of go back and reiterate that this committee doesn't have the ability to authorise any additional monies above the current budget, and also to say that the governing body and CCGs generally can only invest additional monies where it is seen to support the response or recovery to COVID-19 in particular at the moment. I probably would just like to sort of we're talking about additional investment. We have spent, I mean, correct me if I'm wrong, Tanya, we're currently spending 1.3 million on our local service, and we are then also going to be investing an additional 892,000 into this service. So we are investing more into care homes already. I accept that it's different beds, etc., that you're looking at, but this is actually quite a significant investment that's been made, and I would sort of follow up and sort of talk about both Dan and Paula have talked about value for money, and so, you know, I think we really need to be sort of cognizant of the fact that we are investing quite a lot in this through the national scheme, and we need to look at the value for money of the arrangements, I think.
Okay, thanks everybody for that. Is there anybody else that wants to come in before we come to...
Can I come in, please?
Yeah.
totally agree with everything that's been said. I think it's been a really good discussion. I think there's been really good points put across on this. I think as an LMC and a general practice representatives, we fully understand the situation financially the CCG's in. And I'd agree you do need to look at value for money, but practices need to look at value for money as well. So if you're asking them to invest in additional staff with appropriate skill sets, etc., they need some assurance about the income that's going to follow that. Because if the income's not there or it fluctuates, it does call into question whether or not they'll be able to afford to actually employ these staff, and then they could end up with redundancy costs. So there's a whole circle of issues here around funding, etc. I think Paula's points about being very clear on the principles and standards of care you want and the outcomes is the starting point. And then it's really going to be for the powers that be within the CCG to make the decision about the investment. But if the investment's not there, then it would be unsurprising to find the practices wanting to invest their own monies and not invest in other parts of the service they provide to actually provide services for these patients, which is a difficult decision for them as well as to the CCG.
Okay, thanks, William. Thanks for that. In terms of moving on, we need to go back to the options. Can I make an assumption?
Sorry, Pam. Can I just come in? I've put a note on just asking if I, and my point slightly changed because some of the comments that have just come from William and others have covered some of the things I was going to say. I guess there's a general question here. So I think I've heard the message, and I guess I know we're focused on whether the decision can be made here or not, but that's relevant if we are recommending that we take the option with increased investment. And at the moment, what I'm hearing is a general view that technically, even if we took it to a governing body, we probably couldn't do that this year because of the current funding arrangement. So I think the focus has to be on, you know, is there a view that that's not really the option? So I guess I had a question that I just wanted Tanya to come back on in terms of that. Are we clear what other local CCGs are doing? And, you know, just to confirm that we're consistent in taking that view that actually additional investment over the investment that's going in the DES probably isn't a viable option in 2021. The other thing linked to that that's referenced in the paper, and it may be too soon, but there was reference to doing a review of the investment, and I'm including the PCN DES investment there at a point, which I guess taking the outcomes point that I keep hearing from people in terms of need to measure outcomes, need to show that there's value for money. If we are going to review the service and we start to see that this is delivering the outcomes with a what may be considered a partial investment, because clearly the preferred options are more significant investment than I'm hearing people advocating, that gives some confidence that further investment and further capacity going in is a sensible thing to do. I don't know if that makes sense, but I'm just playing back what I guess I'm hearing, that rather than say we're not going to make a decision on something now, you know, option one leading into a potential review to say, do we want to invest more in the future, is what I think I'm hearing as a way forward, but I don't know. Sorry, my ramblings.
Okay, Dan, you wanted to come in as well.
Yeah, I guess I'm just going to follow on from Neil there. I mean, again, my point has changed somewhat since I first put my hand up, but you know, I reflect on the fact that Linda already mentioned we're investing 1.3 million already in the LES scheme, and we're looking at a potential maximum further investment of 500 and something thousand as a max. So I guess the question about the outcomes point is, well, have we got any demonstrable evidence of what that 1.3 million has done already? Because it feels like, you know, in terms of the size of investment, actually it's only what 35% of what they're already getting on top of it. So surely we should be looking for at least the same size of benefit from that initial 1.3 million, I suppose. So have we got any evidence or anything to support the outcomes that we're looking to achieve with that 500,000, which we're already achieving through the 1.3 million?
The problem is we haven't invested the 1.3 million yet because the DES hasn't started or won't start till October. Am I right?
No, we have invested the 1.3 million, which is a local enhanced service amount, and then The DES funding is part year this year, and it's been paid since August.
Okay.
So that funding has already commenced in PCNs.
Okay.
Am I right, Pam? Sorry.
Yeah, surely, go on.
Few of those areas. So first of all, in terms of Neil's point around what comparable CCGs have done, so as part of this work, I've made connections with 3 fairly local CCGs due to their kind of demographic and having similar homes to us. The 3 that I've been connecting with are Stoke CCG, Liverpool CCG and Nottingham CCG. And to confirm, both Stoke and Nottingham currently do make investment and are wanting to continue to do that over and above the direct enhanced service, although that is at a lower level than we are proposing. Liverpool CCG, however, don't make that additional investment over and above the direct enhanced service, and at the moment don't intend, my understanding is don't intend to do that going forward just at the moment. So that's a comparison of what other CCGs are doing. In terms of just coming back on the feedback Louise was giving very helpfully around the work I've been doing at West, linking in with Lee Calvert, I have also obviously been replicating that over in East too. So I've been linking with Joanne Sutton and members of her team to make sure I'm getting that same input into the local authority over in Cheshire East and the secondary care providers there. In terms of the outcomes, I won't go through the figures now, but there is a section within the paper that actually looks at what the benefits have been for the east side of the patch in terms of delivery of the scheme, in terms of reduction in ambulance call-outs, A&E attendances and emergency admissions directly as a result of the implementation of the local enhanced scheme there. I've also then replicated that in West and with a particular focus on the utilisation of risk stratification and multidisciplinary team approaches to patients who are at risk. And finally, you will also see within that paper there are demonstrable improvements in terms of call outs for ambulances, A&E attendances and emergency admissions across Cheshire for homes that have been a part of the local enhanced service historically. So those outcomes are demonstrated within the paper, and what we've done is then looked at, when you look at what that reduction has been, if that was replicated to the levels that we have seen in the homes that are not included as a part of the current local enhanced service. And it should be noted that the activity in terms of emergency activity in those, for example, residential homes is higher than the nursing homes, which is quite interesting when you talk about potentially the complexity of patients within. So if we manage to replicate the outcomes that have been seen in nursing homes to the homes that are currently not covered, so essentially for that potential £500,000 additional investment, that could save us around £1.2 million if that was, achieved up to a maximum level in secondary care activity. So those outcomes have been demonstrated historically, and we have got analysis of what we predict that would do in the future if those same outcomes were replicated.
Thanks, Tanya. I guess just sorry, if I may just clarify a little bit. So do we, obviously we put a financial figure to the benefits of the 500,000 in the care homes. Do we know that the benefit in the nursing homes, as you've explained with all the outcomes that we've talked about, has also got a figure against it? And I guess, is that figure greater than the investment that we put in? Because I think that's what we are talking about here. And unfortunately, as Linda's already highlighted, perhaps now's not a great time because it's not something we're going to easily see the benefit from in the block contract side of things. However, I guess, there are two sides to anything here. One is clearly the patient benefits and the client benefits, because that's the primary goal of what we're trying to do here. But obviously, we also need to balance that value side of things, which has to mean then what's the cost of that. And clearly, if this conversation was post the current COVID in the block contract scenario, it might be a slightly different conversation where we can start to add that sort of commercial side too. So it's really just to understand, is the suggestion then that actually we've invested a lot of money, the savings aren't so great in the nursing home side, but if we extend that out to all the care homes, because of what you've described, the financial benefit in a normal situation would be actually more, if that makes sense, disproportionately better or not? I'm not sure.
No. So I haven't displayed all of the figures within the paper, and I'm happy to circulate those afterwards. But my understanding is that the financial benefits we've already seen in nursing homes is also significant compared to the investment that we make. So just to clarify, it's not going to be sort of disproportionately advantageous for residential homes. We are already seeing those benefits in the nursing homes themselves. And I think the other thing to mention is, although the financial benefits may not be seen this year due to the restrictions we have on our budgets for COVID, obviously the actual patient benefit of not being transferred in an ambulance and admitted to hospital at this time with COVID, the CCG may not see the financial benefit there, but obviously the benefit to patients of not being in an acute setting through the pandemic are still going to be really essential.
Okay,
agree.
Linda, final point, and then we're going to have to move on, I think. Linda? You've got no mic on. Linda, I can't hear you.
Okay. I just wanted to reiterate again that we are investing more, because we're now investing another 892,000. I would like to also say that we are going to review all of the local schemes, I believe, aren't we, in 21-22? So this scheme would be reviewed at that point as well. I think if we're sort of talking about the commissioning and contracting intention, so that should be part of that review. Am I confirming that this will be again reviewed in 21-22?
In a sense, in terms of when we're looking at the whole investment in primary care, this would obviously be a part and would play a part of this review. But this is actually our first part of that overall discretionary review in order to try and get equity across the entirety of Cheshire.
Yeah. Okay. So I really do think we need to look at the value for money. And if we're going to do the review, I think this should be taken into account as well, because I think there are other things potentially that might give us better value for money in some ways. So I just want to say that. Thank you.
Okay, thanks. So what I'm hearing from people is there's probably the potential to have a difficulty even to secure the funding to do this, which Linda's made quite clear because of COVID. And people seem to be, well, Neil seemed to be erring to what I'm going to call option 1A, which is the third option down. What are people's thoughts? I'm going to go around people's vote. I need people who are voting. So I'm going to go around and ask people which option they prefer. Should we be investing more money, or should we try and maintain the status quo, recognizing that 3 PCNs will be disadvantaged? I think that's what I heard.
Sorry,
yeah.
Just the other point to make is we also need to make a decision on those enhanced homes as well.
Yeah, I'm going to move on to that in a minute.
Oh, thank you so much.
I just think we need to decide which option we're going to go for this first, and then we'll move on. I'm going to start with Wendy. Wendy, what's your preferred option?
I mean, my heart is to go with let's put the money in, but I think we actually do have to keep our eye on the fact that we don't have this money at the moment. I think I quite like the idea of doing option. Hang on, let me just scroll back a minute. You offered which ones, Pam? 1A and
it's 1A. It's either 1A or 2. Yeah. Option 2 is one where we have to do a large investment. Option 1A isn't, which is the total tariff at between 303 and 329.
I think, given the caution, I think cautious steps would be my preferred option at this moment. I do wonder about us rolling up other things into this, because I do want to do it. I think that the benefits to us in building up that community base and the primary care networks being able to handle so much more is actually where we've got to move towards. So I'm really behind that. But I think we've got to do this carefully and properly and not tie ourselves up into areas that we can't justify later. So some of the evidential bits that Tanya's been talking about, I think are great, but I think that we need to be a little bit more specific on some of that. So I would probably be more hesitant at this stage.
Okay. Paula, what's your view?
I'm going to go for option 1 because I don't understand how we can say yes to option 2 given the financial information we've been given and, you know, the boundaries within which I think I've heard we're operating today. But I've got a strong feeling in terms of option 1 about supporting as much stability as possible in option 1 in terms of the bed base.
Okay, so you're opting to actually decommission the direct enhanced service. That's option 1.
No, I think we're talking, Pam, I think Paula's talking about option 1 in terms of the funding options.
Okay.
So that would be the DES and LES pooled.
Yes. Okay. Yeah. And that's what Wendy's effectively said as well. Linda.
Pam, just can I make sure that I'm being clear about the fact that I think there is something about making it as easy as possible to administer and not using precious time to work out some of the complex formulas around occupancy, so that my plea is whatever is the easiest way to administer should be something that's taken into account in terms of value, because I would see local authorities and care homes perhaps spending time that would be wasted value. So I think that's actually a really important principle. If we're talking about value, which I've talked about several times today, administering the scheme is also part of that value.
Yeah, yes, okay. Neil.
Yeah, as I touched on earlier, I'm of the mind that it's going to be hard to implement the additional investment above the 890,000 or whatever the figure on the DES was this year. I think there's a couple of key points to mention though that William sort of touched on it. We did have a letter from Branwyn Martin from the LMC in the appendix pack, which highlighted the risk that if we don't go to the full figure, some practices may choose not to sign up, which could leave us with that risk of practices choosing not to implement this scheme locally because they believe it's not viable. So I think we have to recognise that risk, even though I am saying I think we have to take that risk because it's too difficult to implement. I think Tanya specifically mentioned that 3 PCN areas potentially have a lower income with this option than they've historically had, which could lead to a disinvestment by them into their local care homes. And I think we need to work with those PCNs or practices to understand why. And if there's a genuine reason that would lead to disinvestment, we need to agree some kind of transitional plan with them so they don't just withdraw resource from those homes as we go into winter and a COVID-driven winter. And my final point is this, so that there is an argument that's come through this group, the Task and Finish group, and the work that Tanya's done, that there are significant outcome benefits from that additional investment. And I think if we can make this what I'll call partial investment in year 1, and we can see the green shoots that are showing that those outcomes and other outcomes are being achieved by it, that then helps us in terms of a wider review going forward to look at further investment, whether that's directly in general practice or via care communities or whatever they will be. So to briefly answer your point, I'm saying in the financial options, option 1 or 1A, which we can negotiate with LMC colleagues in terms of which is the most pragmatic to implement.
Okay, thanks for that. Linda, are you okay with that?
Yes, I would support implementing 1 or 1A. And I would like it noted that this is actually a 67% increase in the nursing home scheme in terms of funding for this scheme. That's quite a considerable increase. And I think we're not I don't know whether we are seeing that, and it is a significant increase.
Okay, the point's been made, and I also, but you have to remember that the residential homes are being brought in now, and that's made a difference. So yeah, okay.
Just to pick up on that, I've not got all the figures in front of me now, but some of what's been talked about here, I think would actually be a decrease in current costs to some practices, particularly in West Cheshire. So I think Neil's right. I think we need to sit down and discuss this in some detail, because I could see a lot of practices not wanting to take part in it if that happened.
Yeah.
So there is a big risk there.
Yeah, I agree. I agree with all the points that Neil says and the points that people have made. So basically, I think we're agreeing that we amalgamate the direct enhanced service and the local enhanced service, recognizing that there are 3 PCNs that might be financially disadvantaged, but we actually need to do some more work on that with the LMC and with those PCNs. We also need to do some work and plan in a review, so that maybe next year, when we're in a different financial place, we could actually look at this again and see how we can actually invest some more money if that's possible. So is everybody okay to agree that as a way forward? Yeah, I'm not hearing any dissension. Okay, now we've also been asked to look at enhanced care home support, and given the decision that we've just made, can we make that decision, or do we need to say no, actually we can't think about that at the moment? Any views?
Can I add one? I know Tanya will probably say this. We have a specific issue around these homes in that at the moment they aren't receiving cover, and they are amongst our most complex homes. What that also means is we are not compliant with, as a CCG or the practice, primary care networks, in relation to the national DES. So I think we have to make a decision on this, even if it's a recommendation that needs to be approved elsewhere. Clearly, I think that the materiality of this value isn't quite the same as the other one. If I can just make a couple of observations on this one. So this is about some specific homes where the input has been assessed, including by working with medical GP leads within the organised CCG and Paula's team, who are very close to some of these homes, to assess the actual input that's required. We recognise there is some complexity, though, to it in terms of ensuring there's no double funding going on. And by double funding, I'm not meaning to the practices, I'm meaning to the homes, because often these packages are always these packages are commissioned for an individual resident, and sometimes they may be coming from out of area, and the home could well be billing for an element of medical cover, and we could then be asked to fund our practice for the medical cover, meaning the home and the practice are both getting the income, but the home really should be passing that on. So I think there is some more detail in terms of implementation behind this, but I think we can't choose not to progress with this. I think the figure quoted in the paper is the worst case scenario, because based on some of the points I've just made, we potentially would be mitigating some of that cost by ensuring that the home foots some of that bill if they're already incurring that income from other commissioners. So that's just a brief observation for me, but I don't think we can leave these homes because they are currently not covered in any way, and they are amongst our most vulnerable residents.
But won't they be covered by the new DES anyway?
Not at present, because no practice is willing to sign up to the DES for these homes because they believe the workload is totally disproportionate to the income they would receive. So I'm flagging really that this is the worst of two scenarios for these three. Well, for two of the three homes, one of them is covered, to be fair, but for two of these three homes, no one is prepared to sign up to either the DES or any historic LES agreements because it's just not viable for them.
And just to add to that, Neil, in terms of the feedback from the local GP practices that have patients registered there, the model of care that's described within the DES would probably not be adequate for the complexity of the patients within the home.
Okay, Linda, would we have to go to governing body for this funding as well?
No,
I can't hear you.
No,
say that.
No, this level of funding is within both mine and Neil's authorisation levels.
But we still don't have the budget to do it.
No.
We'd have to find the money from somewhere else.
Yes.
But what you're saying, Neil, is that not doing it is not an option. Okay.
Yes, from a patient care point of view, I believe it's not an option. And equally, we know from correspondence with NHS England, they are going to, we aren't compliant with the national DES. So we will be forced by our regulators to do something if we choose to leave it alone, so to speak.
Okay, so can I ask then, because I need to move this on because of time, are people in agreement then that we fund this? Wendy?
Yes, we do fund it. I think Neil's got a point. I think it actually creates difficulties for us because we're funding one and not another. The decisions are a bit arbitrary. So I'm uncomfortable with that it's okay for one and not for the other. And I think we need to really be thinking a bit longer term on this and how we budget for these things, which are mandatory.
Yeah.
And, you know, so I think there are other issues that are actually coming up here.
Okay.
Sorry, can I quickly come back just to clarify a point there? We currently have the 1.3 million going into nursing homes across Cheshire and some residential homes. These 3 homes currently don't have anything going in. So it's not quite as black and white as described there, that we are actually, yes, we're levelling up more than we fund the other homes by, but it's not that we're doing one or the other. These homes are the poor relation to some extent in terms of the cover they're receiving at the moment.
Okay, Paula, you wanted to come in.
Yeah, thanks, Pam. We need to fund and agree that we're going to fund these homes with that. But it is really, really important that there's some additional work done on actually what this is going to cost. There's a new commissioner who pays guidance that has landed into CCGs, which is critical that we look at. And it's also really important that thought is put into what we commission when we pay for these packages of care, these individual bespoke care. So it is really important that we do it, but we're almost agreeing to something without actually fully understanding the costs, because actually of the new who pays guidance, and also as well because of understanding what it is that we pay for when we commission individual packages of care, many of which actually from out of area. So there is some additional work to be done, but it is a risk that has to be managed, and I can see the only way through that is to ensure that we provide some level of funding and support for us to proceed with this.
Okay, so can I ask, and will people agree, if we ask that some extra work's done on this so that we can look at exactly what it's going to cost us, what service we're going to provide, but that comes to us virtually to make a decision, so we don't have to wait until the next primary care commissioning meeting.
Pam, can I suggest what I think the paper is suggesting is that the maximum value is described in the paper, so it wouldn't ever cost more than this. That has already been developed by Tanya and co. So we have the specification. I think it's more about how we mitigate those risks will be updated in the committee, but I'm not sure if there are further decisions needed, or we should provide an update to the committee on how we've addressed these issues. I think the risk of delay means that we'll go into October potentially without having resolved this issue. I hope that's okay.
I'm okay with that. Is everybody else okay with that? Have I got Dan, you've got a point?
Yeah, I was only going to say very quickly that we've got to be mindful of the fact that based on the decision we've just made, and I think the right challenges from some of the GPs is that, you know, there might be future care homes and whatnot who don't have cover. So by making this decision on this one, we are actually setting a precedent. So when we then have a problem 2 or 3 or 4 months down the line where GPs are not covering other homes, that we have a standardized approach. So it's just to make it, I guess, to highlight the fact that by making this decision, we perhaps are also setting ourselves up for how we will have to manage further homes.
Except that yeah, I know Tanya's waving, but we are actually making the decision on the basis of the complexity of the people in these homes, not so you wouldn't class the other homes as these are very exceptional establishments, I think. Okay, so can we agree that? Has everybody agreed? I've not got any dissenting voices. No, good. Well, we're well behind time, says she, looking at her watch. So can I move us on in terms of looking at the PCN does additional roles? Who's going to take us through that? Is that Chris?
Yeah, I will take us through it. So Apologies from Dean, who wrote the paper, but we have Lorraine at the meeting as well, who inputted into the paper. So this is just asking the committee to approve two essential things: the process for responding to primary care network requests and queries, and the process to allow primary care networks to bid against the 2021 unclaimed funding. What Dean has put in the paper with Lorraine's help is some of the context and background around the primary care network DES, what the additional role schemes is, and how we will manage requests as they come in, which they do come in. And helpful at the end, there's also a summary of the spends to date in each of the primary care networks, which I'm sure Lorraine can help with if there's any queries. I recall, again, I could be wrong, I'm getting old now, but I do recall that I think we had discussed this deviation request process before in a previous meeting, but I think this is just laying it down on paper now for the committee to see. So I recall we did discuss it in an earlier paper at an earlier meeting, but now it's laid down for everybody to see.
Okay, has anybody got any questions? No one. Okay, that was no questions. That's good. So are people happy to agree the process for responding to PCN requests and queries as outlined in the paper, and the defined CCG process to allow PCNs to bid against the R's unclaimed funding as outlined in section 3? Everybody agree?
Pam, sorry, I'm just checking, are you allowing us back in as GPs?
Oh, sorry, yes, you're allowed back in now, Mike. I've never had GPs quiet for such a long time.
Oh, absolutely.
You're allowed back in. Do you have a question?
I do have a question. It's just for clarification. So I know there's been a little bit of a rumbling among some of the PCN DES clinical directors about clarity and openness about the decisions that have been made against deviation requests. So can we make it clear in a paper that says what deviation requests there have been? Are they about increasing the maximum number of specific roles as one category, exceeding the amount of funding to particular roles, say clinical pharmacists at a higher band that people are struggling to recruit to and having to consider additional funding over and above the top level of the band, and guidance again, and those deviation requests for roles that we're not technically supposed to be assigning to in this year, but some PCNs may have acquired an individual workforce for roles that shouldn't be available this year. And I know there's some technicalities around that, but I think we need to be clear as to what those deviation requests are and what decisions we've made on it.
Okay, who can answer that for me?
So is this, sorry, Mark, I only caught the end bit of that. So are you looking for a summary of the specific requests that have been approved so far? And
yes,
the reasons why?
We don't have to name PCNs because
right.
It's a sensitivity, but it's about the sort of requests we've had
okay.
in what sort of categories and justifying why we made those decisions.
So we can bring a summary back to the next meeting and we'll anonymise it. On your other point, Mike, which was a good one about clarity, what isn't in the paper is we do have now a standard template for PCNs to complete, which makes it easier for them to put their case together so we can measure it easily against everybody else's criteria. So that wasn't in the paper, but we will re-communicate that out. So for the next meeting, Pam, we'll pull together an anonymised summary of what's been agreed and the reasons why, to take Mike's point, if that's okay.
Okay, so is everybody okay with that? Is there anybody else who wants to come in?
Can I have a follow-up question very quickly?
Yeah.
So again, I don't know if we're able to say here whether we have agreed any additional funding over and above what we should be funding within the DES at the moment.
Sorry, you're back on the DES.
So the PCN DES, this scheme, the additional role scheme, is still part of the DES, but there's a set value for each role. And have we yet, as a CCG Primary Care Committee, agreed additional funding over and above the top level of funding? I suppose the committee just needs to know if we have committed to additional funding there.
So it's Lorraine, the Senior Finance Primary Care Accountant. I confirm that we've not
every deviation that's come through has been considered on a case by case. That was discussed with a small committee, but no finances have gone over and above the allocation.
Okay, thank you.
Is that fine? We're okay? So can we agree those two recommendations? Yes, and we can move on. Is that okay? Thank you. So we're moving on to primary care risks. Who's going to take us through this? The risk register. Have I got anybody here? No? Neil, can you?
Jenny
Is Jenny
Underwood
not?
was due to join us. Is Jenny here?
I don't know if she is.
Okay. I've not directly been involved, but I did have some observations in terms of this. That to some extent, I think we need to start again, if that's correct language. In terms of what's happened here is the risks are built off old individual CCG risks, and I think the world in post-COVID has quite significantly. And I would suggest that we almost write new risks. We clearly consider what's in these when doing that. But if we think about what the key challenges are in primary care at the moment in terms of things like workforce sustainability, estates, obviously the response to COVID and how that's changed how practices are having to operate, I think the world's moved on since these risks created, and I'm not sure they're helpful anymore. That they feel to be missing the point. So I would almost start with a blank sheet of paper and build them up from scratch. But that was my observation rather than I've been involved in this paper.
Okay. Chris, did you want to come in?
Yeah, I hadn't seen the paper either, but I have been on annual leave. So my suggestion would be to pick up what Neil just said, is at the next meeting of the Primary Care Operations Group, who used to look at the risk register before it came here, I will put an action that we take this and update it through that meeting, so that at the next meeting you get the sort of updated set of recommendations, which takes into account some of the things Neil's mentioned, the COVID issues, etc. So you will get an updated risk register from the Primary Care Operations Group at the next meeting. The next meeting of the Operations Group will be September, then when they will consider it. So that will fit in with the timeline.
Okay. Paula, did you want to come in?
Yeah, I just wanted to say that's the approach that's been taken with other committees, is by the time you distill the risk registers from former CCGs and then also consider the context in which you're working, it becomes less relevant really, and almost puts people off wanting to engage with risk registers if you're kind of wading through risks that don't feel irrelevant. So I think it's really important that a piece of work is done is to review the risks, not just to close them and kind of start with a blank piece of paper without some due regard to actually some governance around them and noting why they may be closed. I think that's really important, that there is actually a legacy document for the committee. And then, Neil's point about kind of starting again, but I would like to see that there is some legacy management around this in terms of closure and a clear record, and I think that's what other committees.
Can I just come back? Well, this is the final point. Sorry, Paula, you just reminded me. I think that work was done pre-COVID. So I think, Paula, what's happened is I think there was a formal closure and a reopening of certain risks, which then transferred onto a new risk register. But then COVID happened and we didn't have any more meetings, so I need to re-pick that up through the Primary Care Operations Group. So I think that work you've just articulated has happened, but I will re-pick it up as part of the ongoing work that I've just mentioned, if that's okay.
Thanks, Chris. And Williams also said the workforce and organisational development and resilience and stability need updating. So I know you'll look at that. And yeah. Linda, you point at the format. Is it the format? Linda, do you want to?
There is a Word format that Jenny also has, which makes it slightly easier to see for those of us who are challenged in visually. So yeah, I think it's very, very small and it's very difficult to see because of that. So there is a horizontal Word format that we're using, which is also one of Jenny's formats, which is easier.
Okay, so we're asked actually to note that this is the register, but what we're actually saying is that we need the operational group to go away and have a look at it again and bring it back in its updated form to the next meeting. Is that okay with everybody? Yeah. Okay, thank you, everybody. We'll move on. to the primary care commissioning update. Who wants to take us through that?
Is it me again? I think it is.
I think it is. It's your show today, Chris.
I'm on a roll. I'm on a roll. So this is the regular update to the committee on pertinent primary care commissioning issues. Apologies in advance. Obviously, we do write the papers within the timescales, so there is additional information that's been released since this. But basically, it's an update on the current delegated commissioning issues that we have. I just wanted to touch on the issue item 2.1 PAM. If you remember at the last meeting, we said that at this meeting we would confirm the timescales for Sandy Way branch surgery closure application. So I'm happy if you are to confirm those dates now verbally, or we can send them round after the meeting with the times and dates.
Happy for them to be confirmed.
Okay, so the Overview and Scrutiny Committee of Cheshire West and Chester Local Authority will be looking at the application on the 12th of October, and the Primary Care Commissioning Committee, this committee will meet on the 5th of November to consider the final application from the practice. We will confirm dates, times and venues in the minutes, but I believe that the Cheshire West and Chester Overview and Scrutiny Committee information is already on their website, which is why I wanted to mention it today.
Okay, thanks. I was a bit concerned because I was hoping that we'd have a separate meeting just to look at this issue, but it seems that that's not going to happen now. So we need to make sure that we set aside enough time for the meeting next time to do our business as well as do this, because this can't be done quickly. We're going to have the Save Our Surgery group speaking, and I think maybe, I don't know if Louise knows, but we're going to ask Health Watch to speak as well. So we do need to have extra time. So that's a forewarned. I think the meeting's in the afternoon of the 5th of November, if I'm correct.
If I just come back, and then I know Louise wants to come in. I've just had a quick look. I worked out that the next, let's say the next usual meeting of this committee should actually be in October. So there should be a meeting of this usual at the end of October. That 5th of November, my understanding was that was the special meeting.
Okay.
Because that's out of sync with the usual. So I think somewhere there's an October meeting that hasn't been put in. The 5th has been put in, which is the meeting to consider Sandy Way, which that's my understanding. Because I've been on leave, I may have missed some emails. So we may need to check what happened to October's meeting.
We do, because I know maybe there's some confusion around, because we're trying to move the meetings to a Thursday, and it will have been put in on a Wednesday. So yeah, I need to just flag that up. It needs to be sorted. Okay. Louise, did you want to come in?
No, I think it's covered. I was about to say we've got an internal document around this for our briefing. The surgery has had all the comments back to them that we've received from the public, but I think Chris has just covered it, that we'll be presenting, or we'll be giving an update. I think that's probably the better way to describe it.
Okay, that's lovely. Has anybody got any other questions on this paper? No. If not, can't see anybody waving or emailing. We're just asked to note the update that we've been given then. No decisions, so that's lovely. Let's move on. Our next item is the summary of the GP patient survey.
It's not still me, is it? Here we go. Right, okay. So this is just a very quick summary of the GP patient survey. Within I put in the paper the information in the first paragraph around when the survey was done, how many respondents there were, and when the data was captured. And what we've just put in here is a very quick summary of some of the headings and overall percentage gradings of some of the questions. With what's always interesting to the committee is what are we doing about it included in that section. I've also put in at the bottom on page 62 a screenshot of some of the analysis that was done by the business intelligence team, because it is such a big survey. There's so many results to look at, and just to assure you that there are follow-on actions happening. If members of the committee want to look at the findings in more detail, the link to the survey summary is on there, but it is quite a big document.
Yeah. Yes, thanks, Chris. I know that for me, it's always useful to have a look at broad trends in terms of performance up and down, or whether there's a consistent issue that we've got. And I was interested. I mean, I've been following this for some years, which is very sad. And still people are saying they can't get through to their GP practice on the phone. It's like, and there seems to be quite this time a lack of awareness of online services as well, which I'd never picked up before. So yeah, I find it really interesting. Gwydion, you want to come in?
Hi Pam, yes please. It's just to put a big caveat next to the GP patient survey. You're talking about extremely low response levels. So when you have questionnaires with response rates less than 50%, you really got to worry about whether or not you're getting a representative reply. So it's one of the very few tools that we have. But as I said, if you're going to looking at trends, that can be quite dangerous when you're dealing with quite low response rates and low sample numbers to start with. But I accept it's all that we have.
Yeah, I think you're right, Gwydion. For years when I was in the West, my patient participation group chairs used to look at this with dismay and say it really isn't like that in our surgery. And some patient groups used to do their own surveys and catch people in the surgery, because it's a random, it's sent to a random set of patients, isn't it, who may or may not have had a good experience at the surgery, who may not go very often, even may just have gone as a one-off. So yeah, I understand to take it with a pinch of salt sometimes. Anybody got anything else they want to say? So can we just accept?
Can I? Sorry.
Surely.
I think Wendy wants to as well. So just I'd echo your point, Gwydion. I get it. I get that it's not representative, but it's what we have. What we have done during from the beginning of May, and it's still out there now, is we've got a survey out on people's experiences. And on Monday evening, we were witnesses at the Ovian scrutiny pandemic for around primary care in West. And we have got just over 1,500 people's responses during that time, and it's an ongoing thing. But what I'll probably do is if this works for you, Pam, is maybe have a cut and just see which comments are relating to primary care. And it was a particular snapshot in time, and I get that, and it's people that have responded, I get that, but it is 1,500 of our residents who have said things. So what might be worth me doing is just asking one of my team to cut it where we can see that it directly relates to primary care, and perhaps get that over, even if it's just something for information.
That'd be really useful. Thanks, Louise. That would be really good. Wendy, did you want to come in?
I was really going to just build on something that Louise was saying. It's quite useful if we have comparative data from somewhere else. And I'm not really sure the national responses that we compare ourselves to on the key results section, we don't know what their response rates were. Were they around the 30-odd%, or were they higher? Because we seem to come out better than everything all along there. So I'm not really certain what the learning is that we're taking from this. I don't know where we need to be encouraging sort of improvements. I'm not really clear on it. So whilst it's quite gratifying to see that we are doing quite well, what are we learning from it, I suppose, is the challenge.
Can I come back, Pam, on that?
Yeah, sure,
yeah.
Chris.
So it's a good point, Wendy. So I think I put it in the paper. So the primary care operations group, in fact, there's a meeting this afternoon. We do drill down further onto some of the areas. So we don't just look at the overall summary. We look at where there's big variations between practices and which areas which were generally the more on the lower end. And we do look at other comparisons with other CCGs as part of that. But also, as I was also put in the paper, the Integrated Care Partnership primary care development teams have a copy of all the results that have come in. So their ongoing work with the practices, that's included in part of that. So it isn't just a blanket look and then we don't look, we do drill down on certain areas. If there's areas we think we can support practices further with, then we'll talk to our primary care development colleagues about how we could support that further, for example, getting through by telephone.
Okay. Paula, did you want to come in?
Yeah, thanks, Pam. I just kind of wanted to make a point really about an improvement journey, and this is just one aspect of that which contributes to patients' experience within practices. I think we've got comparators are helpful, but they're also a detractor from an individual practice improvement journey. And the national evidence base, talks about people understanding your starting point as a practice, using your knowledge and your continuity in your improvement journey. And I think it's really important that practices take the totality of information and think about the work that they do with their PPGs, the complaints that they receive, with the positive feedback and the compliments that they also receive, their local surveys that a lot of the practices run, the feedback that they get from HealthWatch visits, the feedback HealthWatch provides in terms of individual comments from patients. So that builds up a repository of information for a practice, and it's about the time and attention that practices have got to be able to give to that totality actually of that intelligence, and look at their areas where that they can see the insight and the intelligence. And often it's when you work within a practice that some of it makes more sense to you than some of us that are looking at it with an external lens. So I think it's really helpful to see some of the headlines, but it's the granularity that's really important at a practice level, but to that practice, and understanding what practices do with, like I say, the whole tapestry of information that they receive. And I think from a patient experience, sort of a strategic approach around primary care, got many practices already do put a lens and time on this and talk about this at practice meetings. And I think there's something about how we capture the totality and really understand some of the work that practices are doing on their own improvement journey.
Okay, thanks, Paula. Does anybody else want to come in? No? So can we just accept that report for noting? Yeah. Our next item is the COVID-19 GP practice infrastructure funding paper. Who's going to take us through that?
I can talk about this on, it's James Birchall for the head of estates for the CCG, if that's all right, Pam.
Yeah, that's fine, James.
Yeah. Okay, so there was requests to do with infection control bids for primary care premises, and we had obviously been in discussions with NHS England on a number of potential schemes to facilitate this. This particular phase of this scheme was broken into two halves. Bids that were less than £5,000 would be included in our regular COVID claim as long as we got them in within a certain deadline. And there were bids that is covered under 2.10 of this meeting that were covered under for bids over 5,000. So this particular point covers those bids that are less than 5,000. We've gone out to primary care and with an ask of could they get quotes, could they demonstrate value for money, and primarily could they demonstrate that they are directly related to infection control. So typical bids have been coming in for changing carpet within practices to clinical flooring. Carpet is obviously, if you've got patients that have been potentially at risk, would need cleaning. There's a delay and an expense in doing that, as opposed to sort of the clinical flooring that could be provided. So those are the basis on what we've done. We've given or Dean's provided a very brief overview on examples, etc. But we have emphasised that the two schemes that we've got below, and certainly the one above that I'll talk about later in section 210, are directly related to infection and prevention of COVID.
Okay, we're asked to note this report. Has anybody got any questions? Gwydion, you have.
Hi, James. Thanks.
Hi.
I know it's difficult, and I think it's a great piece of work. The question I have is, I'm worried about compounding inequalities across the patch. And I was interested to see that approximately 25% of practices didn't put a funding request in. And I'm concerned that that will reflect the tight timescales and the difference in the ability of those practices to engage. And ironically, probably those practices would benefit the most from engagement.
Yeah.
So it's an ask, I suppose, to see what can we do going forward to help those practices that, as I said, will probably benefit the most and who probably have the least ability to engage. Because what we're seeing with COVID especially is a high burden of the disease and the impact in poorer areas. And you might be able to reassure me that that's not the case. But when I see sort of from the rough figures that 25% or so of practices have not put a request in, it just jumps out at me a little bit. It's not to detract from the work. I think it's great, but a question on that, please.
Yeah, clearly we sent this communication out to all practices, so everyone had an equal opportunity. There has been a number of schemes that have happened before this piece of work where we had sign off of things like reception screens and other smaller pieces. So whilst this might represent only the 25% of practices, there's probably already been expenditure incurred already in the earlier months of COVID that is representative. So I suppose we need to sort of eventually consolidate all of those and say, well, how much has been spent on each practice as an exercise, possibly just to give you that confidence and assurance that we have been as completeness or complete as we could.
Okay, thanks for that, James. Neil, you wanted to come in?
Yeah, it's just to clarify a point that what is in the paper, just to confirm, this one's only coming for information because it was COVID related expenditure. It's been approved through the CCG internal COVID group rather than needing approval here. But as I say, specifically because it was COVID related expenditure.
Okay, that's lovely. Anybody got any other questions? Mike?
So a quick one, I agree with Gwyd, but I suppose the other thing to bear in mind is that different premises are potentially COVID ready because of their newer builds, whereas older premises might have found it more difficult. So I would expect more investment in those older properties that would have found it harder to be COVID ready as well.
Yeah. Okay, thanks, Mike. Anybody got anything else they need to say? No? So we just note that report, and can we move on to the next item, which is, it has got a front sheet, but it's the primary care flu vac planning arrangements. Does anybody want to ask any questions on this? Oh, Wendy. Wendy's got a hand up. Wendy.
Sorry, I didn't type instead. Put my fingers up. I found this absolutely fascinating, and it's a really valuable paper. And one of the reasons I think I was dismayed to see that we're looking at a tremendous drop in vaccinations due to the pandemic. But what was crossing my mind is what can we be thinking about when, or if and when, a vaccine comes up for COVID, and there may be higher demands on delivery of those vaccinations at a higher rate to vulnerable, elderly, all the populations we're talking about with this. I mean, we don't know how long it's going to be before we actually do get a vaccine, if ever. But this is a bit dismal in terms of being able to access the population that does need. So I was concerned, really concerned, but I found it a valuable piece of information. So anyone, any of our GP colleagues who could comment on that would be really, really useful.
Anybody wanting to come in?
I've just sent a quick message saying I can come in. And I suppose, again, it's about timing of this paper. I suspect if we go to practices now and ask about readiness for flu and what preparations they put in place, there's a lot more preparedness. I know for us in Macclesfield, we were having an internal debate as to who was going to go into the flus at AstraZeneca, who was going to go into do them within buildings. So those plans have been morphing. So there's probably more information to come. My other concern is actually about pharmacists, because pharmacies are going out there already and targeting patients and trying to pull them away from primary care, and we're having patients cancel our flu clinic appointments. I'm not sure pharmacies are necessarily offering specific appointments in the same way we are and complying to the same rigid structure that we need to as far as social distancing and timing of appointments. So there's a bit of a potential impact on primary care income there, possibly, if more is taken from pharmacies. And there's an assumption in here that last year's pharmacy activity would have probably come back to primary care. I'm not sure that's going to happen. And the other thing we have to bear in mind is that practices will be offering other vaccines as well as flu vaccines, which pharmacies won't be able to. So practices are still going to have to pick up that other activity in a social distanced way going forwards. So again, if the activity is coordinated in primary care, if we do ultimately get a COVID vaccine, I would say practices are in the best position to be able to do that. We would probably find ourselves next year offering a flu vaccine and a COVID vaccine, because it's unlikely to be a combined vaccine by then. But because practices can offer multiple vaccines in the sitting, we would be in a better position to do that going forwards.
Okay, thanks, Mike. Louise, you've got a question, and then Gwyd.
Yeah, so brilliantly, Mike answered my question before I could ask it, but I've got a supplementary to that. Is, okay, so what are we telling the public? So I sat here at Health Watch. Are we pushing get your appointments at your GPs, or are we saying actually go ahead, pharmacy? What is the CCG's message around this? What is it we're telling? So we've already had people saying I can't get an appointment to get my flu jab, and it's like they're not releasing those yet, and the doctor said bring them back next month, but I can go, and it's I don't know is the answer. So I guess it's a steer from the CCG around comms, and I get that, but just actually from a GP perspective, what are we telling people?
Okay, Katie, you're waving at me. Do you want to answer that? Is that why you're waving?
Yes, sorry, I'm typing away, but I'm typing on the wrong keyboard. It was just to say there was a really clear comms strategy this year for flu that's taking some of the national direction and also some of the CCG messaging. It is really complicated this year because we've got the extended cohorts of the 50 to 64-year-olds, but they're not going to be vaccinated until much later in the season, probably November time. And that vaccine stock has been procured nationally. And as yet, we don't know how that's going to be delivered or distributed throughout primary care, if it's going to be primary care that's delivering it. So there's still a lot of questions that we're waiting for national clearance on. But like I said, there is a really clear comms strategy, Louise. So I don't know if that's something that we can link you into. I know Charles Macon is leading on that piece of work.
Okay. Woodian, did you want to come in as well?
Yeah, I think it's a really important discussion. I think Louise's point about clarity of message is extremely important. This is not something that's crept up on us. We were fully aware that we were wanting to have an enhanced flu vaccination schedule of some description, and it's been discussed time and time again. With my practice hat on, general practice is agile and general practice can adapt. But as with all businesses, they need a certain timescale to work to. And if we consistently wait for national messages, we'll find that a lot of our opportunity to be agile is gone. It's also difficult when we allow different providers to essentially pick the low-hanging fruit. And that's what happens with the pharmacies. So when you're talking about the additional benefits that are hard to measure, such as other vaccines which are done in the same appointment, other health promotion which is done in the same appointment, discussion around, well, do different providers follow the same safety with regards to providing vaccines? You know, these thoughts need to come into the discussion. And with my general practice hat on, I see a lot of scrutiny on what general practices are offering across a number of different services, but not so much on what other providers are offering. And this means that those practices that really want to invest and they really want to provide a good level of service, they can't, because the time taken, the lead time that's required with regards to putting in your order for the vaccines, making sure you have the cold storage, making sure that you have a suitable environment to provide the vaccines, the time evaporates. And I think Mike's point about the question of the moment in time with this information is all old. So there are actually, for me, there are very few lessons in this document. And it's about trying to move forward with more agility, more pace, and to be braver, and to have a clear strategy with all who do we want to provide these vaccines. As a GP, if you tell me we want the pharmacies to do all of it, great, do it. I'll stand my staff down, I will adapt what I do. But the later we leave things all the time, the worse it gets. So it's just to really get that message clear into the consciousness of this committee that general practice can do it, general practice is agile, but it mustn't always be picking up the hard to reach cases, because that makes it too difficult.
Okay,
thanks.
Good. Leslie, did you want to come in too?
Yes, I just wanted to make a point about sort of shielded patients, really. We're going to have much greater numbers of patients that are requiring sort of specific, I suppose, sort of immunisations at home, and these are the vulnerable groups. These are the ones we want to be immunising. So I worry that potentially these people are going to get missed. District nurses, we're saying that they should be taking some of the workload. They're already overwhelmed. Often it's practices who take on this burden, and actually it takes a long time to go out to a patient, administer an injection. You could only get to sort of 5 or 6 patients within a morning. So it's how we manage that, and we need to think about that, because we will have more numbers of vulnerable patients who won't be able to come into the practice, or we need a separate, I suppose, more clean environment, and perhaps a bit more guidance from the CCG about how we manage these specific patients.
Okay, who manages this on a day-to-day basis? Does this sit with the ops group as well? Who's got a handle on it is what I'm asking.
Yeah, we have got a flu group set up, which has got people from across the organisation, including Branwen from LMC has also joined that group helpfully. So we have got a group. I guess this is, a challenge between the local opportunities to implement and then the national information. So I'm not sure if Jim's still on the call, who's coordinating that group, or Chris, who was sat on it. But there is a local group who can take back some of these comments and get a response. I know there was a meeting yesterday which I wasn't part of, and they were working through a number of the queries that have come in to get an update out to primary care. Clearly, as I say, it's a challenge when some of it is nationally commissioned, and we need to get to that information to answer some of the questions, noting that some of them we can locally provide help and support on. So we need to do what we can.
Is there going to be a flu campaign this year, same as there usually is?
Yes.
Yeah, okay.
Can I just come in as well? I totally agree with everything that Gwydion said. I mean, the lateness of the national guidance, I suppose, is unexpected. It's not very helpful, but it does make us less agile to deal with these things. As Neil said, there are groups looking at this locally, which is helpful. I've been in touch with the LPC that covers the pharmacists. We're very keen to have joint messages go out, but the difficulty we have is that pharmacy is not managed the same way, organised the same way as general practice. There are a lot of national firms involved in this. They see it as a business opportunity. So there are some complications around that, but the LPC and the LMC are very keen to work together on getting the right message out.
Thanks, William. That's really helpful. Has anybody else got any other comments or questions? No.
Really briefly, there's a whole thing about people still not going to their GPs, still not wanting to go, people not wanting to burden their GPs, and going for a flu vaccination in a GP setting. Lots of people will perceive that as a burden when you can go somewhere down the road that is doing it and advertising it on their window. So we do need to factor all of this in.
Yeah, thanks, Louise. I see that. Okay, so can all those points all be picked up by the flu group for us, please? Thanks, Chris. He's nodding his head. That's lovely. Okay, so we've noted the survey which we were given. I'm going to move us on. We've got a finance update now. Is Lorraine still with us?
I'm still here, yes.
Hi, Lorraine. I
So
think
apologies.
Assume
Sorry?
people have read it, I think. Has anybody got any questions? I think that's going to be the best way to go through.
Yeah.
Anybody got any questions on this paper? No? Nothing? Was there any pertinent points you want to point us to, Lorraine, or is?
So I think Neil's touched on, we spoke about the QAF elements, so we do have a query around QAF, so we've got an appeal there.
Also just around, obviously we haven't got the allocations for the whole year, but we have put in a position which is a month 12 forecast. But obviously we're not going to be sure what the variance is against the allocation until we receive that. And it's just if anyone's got any further questions.
Okay. Gwydion, you have a question?
It's a very minor thing, but I think on page 8 of the appendix, I think seniority is gone now. So seniority was paid out in March, I think. So it's just
yes, it has. Yeah. We'll remove that.
So we're asked to note this report, I think. I'm just going back to the recommendations. Primary Care Commission is asked to note the financial position and note the financial risk. So can we all accept that paper? Mike, did you want to come in?
Yeah, sorry, it's a very minor one, a quick one. I just wondered if, and it's possibly related to the CCGs merging and different values moving through the different books to get a single book for Cheshire CCG. But is there a possibility that some of the old funding lines have moved into the COVID-19 primary care lines? I'm just thinking things like IT for primary care has gone down as its spend. So is some of that actually being offset into the COVID monies instead?
So for the IT, as in comparison to the allocation, you mean, or in comparison to the last year's?
The variance, yeah. So on page 73 of the full pack, in those two tables, the local CCG primary care budget, the variance is down 73,000 for IT primary care. So I wonder whether it's because some of the IT costs have been offset into COVID or not.
So some IT costs have been offset by by COVID, that's correct, yes.
Right. Thank you.
Anybody got any other questions? No. Okay, so we can accept that report, which was for noting. Can we move on then to the IT update? Has anybody got any questions on that? No.
Kevin has got some items he needs to just run through, haven't you?
I have, yeah. Thanks, Pam. Just for those who don't know me, I'm Kevin Highfield. I'm Head of IT and Service Delivery for Cheshire CCG. It was basically, this paper was to bring the committee up to speed of items that have happened during COVID. I'm acutely aware that it's been, a while since we've had some updates of what's been going on in that area. Some of the projects and the asks in this paper were projects that were funded and bid for in the previous year. And it was just to give assurance to the committee that those projects will now restart in primary care for the benefit of primary care, with an assurance that the funding is still available as part of our funding stream to continue with them. So there's no new funding required to proceed with these projects. So if there are any questions on that, if the committee's happy with those funding arrangements.
Mike, you've got a question, I think.
Just a quick one, Kevin, for point of clarity. So when we talk on page 80, 1.3, patient online triage, going forward, are we going to be just having one CCG option for online triage? Or are we going to allow practices a choice of online triage? And then obviously, whichever one is the most cost effective, giving the best interface for both patients and GPs. So we're going to give choice, or we're going to just have one choice?
So good question, Mike. On that, we've got a view of, there's a strategic direction for that and a tactical decision, if you like. The main thing was to make sure all practices had a solution for compliance with the national DES, which we are currently finalising at the moment. But your point is, we are looking and working with PCN directors, with Dr. Dan Jones, the ICT lead, to understand what those requirements are. There's a lot of new products and new suppliers coming on board, obviously a changing face of requirements. So I think the choice element would be the thing that we should be looking at strategically, because there are variances in PCNs, there are variances in requirements and suppliers' offerings. A lot of that may be funded via the new GPIT Futures funding streams, which we are still awaiting national guidance and confirmation on of what they will look like. So, but yeah, hope that answers your question.
Okay, has anybody got any other questions for Kevin? No. That's it. Lovely. So we can accept. Sorry.
Sorry, Pam. There's just one other element in the paper, though, which was it's effectively the re-procurement of ICT. It was just to bring to the committee's attention that the ICT contract is due to finish with the current supplier at the end of next year. Obviously, due to COVID, we haven't been able to go to a full procurement exercise at this point. National guidance and has given us a variance to extend that contract for 12 months. But it's looking to then continue that procurement and fulfill that full ICT procurement for a new supplier going forward for 22-23 and onwards. Again, Dr. Dan Jones and myself are working with PCN directors over the next few months to understand where the perceived gaps in ICT services are, how we can try and fulfill them with a new contract, and obviously consider what the change in the ways of working with primary care practices are as part of COVID, and obviously the national DES as well, and try to accommodate those.
I noticed from that paper, Kevin, that there were some recommendations in that. Do you need the committee to approve anything?
No, I think it's just really to bring to the committee's attention that you know what work is going on at the moment, and to be assured that that is progressing. We would have to take this to governing body as part of the financial value. So again, it'll come back, and I'll bring regular updates to the committee to say how we're progressing with this procurement. Okay, that's lovely. So if there's no further questions, I'm proposing to move on because that item was actually for noting. So is everybody all right with that? Our next item is estates update. If I can get to it. Is that Kevin?
No, that's James.
James, sorry, James. Yes, go on, sorry.
So it's just a very, this is the other side of 2.6. So this relates directly to the bids that were for more than £5,000. NHS England gave us some advice and procedures on how we needed to claim for these. Each GP practice was again contacted, and we needed to apply for this funding through the improvement grant process. So typically 3 quotes would be required, but because of the very short notice, we've managed to secure just 1 quote, with other quotes being obtained whilst we're waiting approval. We've had a total of £483,000 worth of bids submitted to us, of which we've taken forward £212,000 worth of those bids for approval by NHS England. That process should hopefully be happening mid-September, and we'll be advised of the decisions hopefully shortly after that. So it's just really for noting. Again, these were more substantial bids. These were anything over 5,000, so maybe some minor changes to structural, but with the emphasis still on infection control.
Okay, Gwydion, you've got a question?
Hi, James. Yeah, great, thanks. Really looking at 1.8, so looking to try and guess the next offer that comes, because my concern is that when the offer comes for making additional grant requests, again, the timelines will be tight. Again, it's about trying to make sure that those practices that potentially are left behind are supported to get their buildings up to spec with regards to infection control. A lot of the big tensions in general practice at the moment are around capacity issues and the fact that pre-existing buildings, when you work them in a COVID manner, do not offer the same capacity as before. So it's a request really. Can we try, and I'm quite happy to give my time, I'm sure lots of clinicians will give their time. Can we try and think, well, how can we be ahead of the curve? So when we get our next grant window, that we already have some solid applications which are good to go, which are dispersed over the whole of Cheshire, so that we get the best crack at this whip. Because I think there's going to be a lot of money that's coming, and they will want it spent, and we want it spent effectively in Cheshire. You know, I was thinking mainly around the bigger works. So, you know, with the need for getting some architect input, potentially getting building control, etc. You'll know a lot more about that than I will. I was just wondering on your thoughts on that, please.
So a lot of the bids that have already been presented do include aspirational developments that might not be directly related to COVID. They are indirect consequences, extensions, because reception areas won't deal with things, would deal with the capacity. So it has been a good exercise, and NHS England, we have already had a discussion with NHS England to say that there may be another crack at the whip, as you say, to try and secure that extra funding. We have also got a primary care data gathering exercise that will be pulling together a number of requirements through primary care. This is a baseline exercise where everyone is going to be assessed on the same criteria, and we are expecting that information to be ready probably early next year, and that should allow opportunities for developments in a very fair and equitable manner across a regional, should any capital be available. So we are sort of tackling those things, but this has given us an initial view that there are still some very aspirational things that, whilst might not be COVID or infection control related, give us the quote. We've got quotes now that should NHS England have some slippage monies, that we could use those initially for those tranche of work.
Okay, thanks. Has anybody got any other questions? No. So we're asked to note the COVID-19 improvement grant process and that bids have been submitted to NHS England for funding and or approval. That, I think, is the last item on our agenda, unless anybody's got any other business. No? Okay. I note from the agenda that it says the next meeting is Thursday, the 5th of November, but it may well be before that, in the end of October. So we'll get something round to you pretty quickly about that. So that ends the public part of our meeting, and we're moving on to Microsoft Teams, I think, for part 2. If that's all right with everybody, I'm suggesting, even though we're supposed to finish by 11:30, that we won't, that perhaps we take a 5-minute break now and we start the next meeting, shall we say 20 past, 25 past. Is that all right with people? Yeah, I know it means we're starting nearly half an hour late, but I just think we need a bit of a break. So thank you, everybody, and I'll see you on Microsoft Teams in 10 minutes.